This conference will now be recorded.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. أقم الصلاة لدلوك الشمس إلى غسق الليل وقرآن الفجر إن قرآن الفجر كان مشهودا ومن الليل فتهجد به نافلة لك عسى أن يبعثك عسى أن يبعثك ربك مقاما محمودا. صدق الله العظيم. Jazakallah, Hafiz Talha, uh, taking this opportunity. uh, Quran is humanity guidance. It has 6,000 plus ayat, but many of the important ayat are repeated. And if you are seeing 200 nafal, the thawab of understanding one ayat is superior. So for us, we need to know how much time that we need to spend and get maximum. So understanding in ayat when we recite, when and tell other people. So coming back to this is the OSP function, and I would request President-elect Professor Javed Iqbal to come to the rostrum to start this function.
Bismillahirrahmanirrahim. It's always a great pleasure for me to come here. Initially, it was the driving force was Dr. Darisa, but now all of you, especially uh, Dr. Prabhat, Dr. Kashif Iqbal, it's really a great occasion for me to come here. As far as this clinical meeting is concerned, you know, OSD Lahore is always trying to uh, do efforts for academic activities. And I think all of you should, especially I'm talking to PG, all of you should participate in these meetings because there's great opportunity of learning. And I would request Dr. Akil Ghazi, Dr. Vasa, Dr. Javasa, and Dr. Bashar, if you can spare your residents to attend the clinical meetings and other hospitals as well, it will be great benefit to them. Apart from all these things, I would like to tell you that this year, OSP Lahore is recognizing Lahore of Film as years, but there is addition of such specialty that is trauma. You know, trauma is very important and it causes loss of being in lot of persons every year, everywhere in the world, especially Kerala. Asia Pacific Society of Trauma, Dr. Khan tried to bring the meeting here, and ultimately would have succeeded to arrange this meeting in Lahore. It's my request to all of you to prepare your papers related to trauma this year. This will be a great learning for you. I would like to say one thing that you people are very lucky in having such a great facility led by Dr. Khalid Saab. I think Dr. Kashif Iqbal, Dr. Jawad Binyamin Bhatt, and Dr. Fabadur Rahman Sahab, they are doing work of international repute, but I'm sorry to say, don't mind it, you are not publishing it. You are not only you are not publishing it, but you are not propagating it as well. क्योंकि आजकल जमाना डोल जाने का है कोई छोटा सा भी काम करता है वो 10 जगहों पे उन्होंने डाला होता है और मुझे कल एक मौका मिला है पेपर देखने का पहले मुझे नहीं पता था कल या 2 दिन पहले डॉक्टर रायान जो ओटीटी के साथ सर्जरी हुई है डॉक्टर काशिफ ने सारा किया हुआ है लेकिन कहीं किसी को पता नहीं इट्स माई हम्बल रिक्वेस्ट कि काम को आप कर रहे हैं उसको थोड़ा सा पब्लिश की तरफ ध्यान दें और साथ थोड़ा बहुत डूब जाने की जरूरत होती है ताकि दूसरे लोगों को भी पता चले कि यहाँ पे क्या हो रहा है क्योंकि अदरवाइज तो कॉन्सेप्ट अबाउट LRBT फेको एंड फेको आई थिंक यू ऑल ऑफ यू नो दैट लेकिन जब इतना अच्छा आप काम भी कर रहे हैं तो उसको प्लीज इट इज माई हम्बल रिक्वेस्ट टू ऑल ऑफ यू स्पेशली काशिफ फवाद एंड जवाब गाली साहब तो हमारे कहने से आज बहुत आगे निकल गए हैं इन्होंने तो जितना काम किया है मेरा नहीं ख्याल कि दुनिया में किसी से भी कम किया हो बल्कि दुनिया में बहुत सारे लोगों से ज्यादा किया है लेकिन इन स्पाइट ऑफ द फैक्ट दैट आवर मेंटर my mentor and Dr. Prima Prasad mentor, Professor Abdul Jalil Dolawat always said, publish our parents. मैं खुद भी मुझे पता है कि मैं दूसरों को नसीहत कर रहा हूँ खुद मैं नसीहत हूँ लेकिन हमारा दौर जो है वो निकल चुका है अब जो आगे जो आ रहा है उसमें पब्लिश की बड़ी बड़ी बहुत ज्यादा अहमियत है आई एम वेरी ग्लैड डॉक्टर हमजा तैयब he is doing effort is always sending the video to social media. That is a very important thing to share all of these things. Now, I will not, I think you are getting late, I will not give back. I will request Dr. Aslan to come here and take the stage to proceed the clinical treatment. Please.
Assalamu alaikum. Thank you, Dr. Professor Javed Chaudhary. First of all, I would like to invite Dr. Kashif to come and give presentation. Thank you.
Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Kashif Hanif. Assalamu alaikum. I'm Dr. Kashif Hanif, resident third year. in LRBT hospital. Today, my case is a 7-year-old boy, resident of Nimzana Saab, presented to us with complaint of drooping of eyelids and restricted eye movement in both eyes. Patient was in usual state of health 20 days back when he had a road traffic accident in which he remained conscious. He was taken to the nearby hospital for minor injuries. During hospital stay, in emergency, he developed diplopia and the symptoms were associated with low-grade fever and pain in ocular region that aggravates with eye movement and was relieved only by medication. Diplopia subsided after 4 days, but doses persisted and restricted eye movements were noted. Drooping of eyelids do not aggravate as the day progresses. Patient had no complaint of decrease of vision, floaters, flashes, or headache after trauma. Past ocular history, past medical or surgical history was not significant. Although patient was on some medication during his stay in hospital, but could not recall the drug. There was no known drug related. In ocular examination, visual acuity was 6.9 in both eyes. IOP on definition tonometry was 10 and 12 mmHg right and left eye respectively. Pupils were round, reactive, and regular in both eyes. Relative operability defect was absent. Restricted extraocular muscle movement in all directions was seen in both eyes. Adnexia was normal. On slitless examination, there was mild ptosis with lid crease present, good levator function of 12 mm, and marginal reflex distance of 2 mm in both eyes. The rest of the anterior segment examination was unremarkable. In dilated fundus examination, there was cup to disc ratio of 0.4 in both eyes with normal fundi. Cranial function tests were done. In optic nerve function test, visual acuity was 6.9 in both eyes. Relative operability defect was absent. Color vision 15 out of 15. Both eyes contrast sensitivity 25 by 25 both eyes, and light brightness sensitivity was normal in both eyes. On visual field could not be performed as patient had restricted eye movement. In rest of the cranial nerve, there was bilateral complete ophthalmoplegia. Corneal sensitivity was intact in both eyes. Sensory component of trigeminal nerve was intact. Motor component of trigeminal nerve was intact, and muscle of facial expressions are normal. In ocular exam investigations, 4 different tests were performed which show reduced mobility in all directions. These are the pictures of the child, which was taken after the treatment prescribed by us. In this from above downward, you can see the patient is trying to look at the left, to the right, uh, downward and upward. Systemic investigations were done. CBC was within normal limits. CRP, C-reactive protein, was raised. Blood culture was negative, and RFP was within normal limits. ECG was performed, which turned out to be unremarkable. Nerve conduction studies, electromyography was done, and it was also normal. MRI brain and orbit. MRI brain and orbit was advised, and it turned out to be a normal MRI brain and orbit. No intraocular pathology was seen. Management. We prescribed patient with oral prednisone 15 milligram per day, upon which process of patient has resolved and mild improvement in upward gain in left eye was seen. Syrup mucane was prescribed as gap recovered. Differential diagnosis of idiopathic orbital inflammatory disease, chronic progressive external ophthalmoplegia, myasthenia gravis, Tolosa syndrome, and orbital cellulitis were made. Thank you so much. Yes, sir. Yes, sir, it was important, but it could not be done. As we asked the patient to come for follow, but he didn't showed up. Sir, the most diagnosis is idiopathic autoimmune inflammatory disease. Sir, actually, we tried to attempt it, the patient was very non-compliant. Uh, yes, sir. Right, sir. While doing visual field, yes, the patient was actually non-compliant. No, sir, as patient was from a low middle socioeconomic status, so he cannot afford that. And we prescribed that to the patient, but patient didn't came back for follow-up. The CT scan is much important always for soft tissue, sir, and bone involvement. Sorry, sir. So we will try to give it for 2 weeks, and then we will see the response. If it doesn't respond to that, then we will shift to the next medical modality. Sorry, sir. Patient was improved after giving oral prednisolone, and we showed much improvement in sources, and in left eye showed upward gaze, also movement in upward gaze. So patient is improving by giving oral steroid prednisolone. In yes, sir. In there was no on the latest fundal examination. There was no pigmentary changes, and on ECG was unremarkable. It doesn't show any conduction defect. That rules out cancer, and in isolated chronic progressive stenocephalopedia, it usually present in a young adult with asymmetrical doses. Our patient has symmetrical doses in both sides. The EMG was performed for myasthenia gravis. For cardiac conduction defects, we performed ECG. Sorry, sir. सर कंडक्शन डिफेक्ट आते हैं कैंप फायर में सर देश आपको डॉक्यूमेंटेशन के लिए हमने ईसीजी कराई है ताकि अच्छे से डॉक्यूमेंट कर सकें सर फॉर जनरल फिजिकल एग्जामिनेशन ऑब्वियसली पल्स इज इम्पोर्टेंट यस सर तो थैंक यू सो मच सर
Thank you, Dr. Kakasani. Our next presenter is Dr. Aisha Arif, third year resident scientist.
Assalamualaikum. I am Dr. Aisha Arif, third year resident. The topic we are going to present is definite and weight attachment after cataract surgery, management and outcome. We have this patient Mansoor Ahmed, son of Noor Mohammed, 73 years old, male, married, who presented to us with a complaint of bilateral decrease of vision, which was gradual in onset, painless, with no associated symptoms. There was no significant past medical or surgical history. On examination, visual acuity of right eye was counting finger and left eye was hand. Best corrected visual acuity of right eye was 618. Intraocular pressure was 17 and it was effective. Lids and next were normal on both sides, cornea were clear on both sides, and pupils were round, regular, and active. Anterior temporal depth was 1 headache grade 4 in right eye and 1 headache grade 3 in left eye. There was grade 2 nucleus fluorescence in right eye and grade 4 nucleus fluorescence in left eye. Fundus examination of right eye was normal and there was no funded view in left eye, so the CT scan was performed, which was unremarkable. Phacoemulsification with posterior chamber intraocular lens under local anesthesia of left eye was advised for this patient. It was a routine surgical case and surgery was performed. This was the condition of cornea on first postoperative day. Patient had circumciliary congestion, corneal edema, and grade 4 striate keratosis. The treatment given was Bedford eye drops 1 RD, Megamox eye drops 2 RD, and off-hypertonic 9 eye drops 4 times a day. Patient was called for follow-up after 1 week. On first follow-up, corneal edema was still the same. There was grade 4 striate keratosis. Inferior descendant detachment was noted, but due to severe corneal edema, it was very difficult for us to assess the extent of this detachment, but it was roughly involving inferior half of the cornea. We advised intracameral gas injection for this patient. Patient was called in operation theater and a anterior segment OCT was performed before the procedure on the operating table. This is the anterior segment OCT which shows the detached descendant membrane. This is the detached descendant membrane. The procedure was performed. Gas was injected in the anterior chamber using 26 gauge bent needle through nasal paracentesis. The gas used was sulfur hexafluoride. 1 ml was diluted in 5 cc which made a total concentration of 20%. Gas is injected in the anterior chamber and a little bit was aspirated out to prevent the complications of IOP light and pupillary block. The surgeon is roughly assessing the intraocular pressure. Gas bubble stays in the anterior chamber and the patient was advised to remain in supine position for 1 hour. Anterior segment OCT was easily repeated after this procedure on the operating table, which shows the descendant membrane was completely attached. Patient was called for follow-up after 1 week. This was the condition after 1 week. It was quite satisfying to see this cornea because cornea was clear and corneal edema was almost completely resolved. Gas bubble is present in the anterior chamber, which is almost filling 2/3 of the anterior chamber. Anterior segment OCT was repeated after 1 week, which showed completely attached descendant membrane. On examination, visual acuity was counting fingers, intraocular pressure was 15. We were unable to record the endothelial cell count of left eye, but in the fellow eye, the cell count was 3062 cells per millimeter square, which is a very good cell count. Patient was again called for follow-up after 1 week. On second follow-up, this was the condition. Cornea was clear, corneal edema completely resolved, gas bubble is present in the anterior chamber. Anterior segment OCT was again repeated after 2 weeks, which showed attached descendant membrane. On examination, visual acuity was counting fingers, intraocular pressure was 11. We will still follow this patient until complete resorption of gas bubble takes place and visual acuity improves. We will monitor his intraocular pressure and perform best corrected visual acuity on follow-up. Now, a little bit of talk about descendant membrane detachment. Some of the causes of descendant membrane detachment are intraocular surgery, blunt ocular trauma, chemical injury, especially alkali burn, and spontaneous after acute eye drops. Some of the risk factors during cataract surgery are poor clear corneal incisions, blunt instrumentation, dense cataract, pre-existing endothelial disorder, inadvertent damage by surgical instruments. Clinically, we can classify descendant membrane detachment according to the extent of involvement into zone 1, 2, and 3. Zone 1, central involving central 5 mm of the cornea, zone 2, paracentral up to 8 mm of the cornea, and zone 3, peripheral beyond 8 mm of the cornea. It can also be classified as DMD separation into planar and non-planar. Planar less than 1 mm separation of descendant membrane from stroma, and non-planar greater than 1 mm separation. And on the basis of DMD conformation, we choose fold if it is a fold edges and non-fold if the edges are non-fold. So on the basis of length of involvement, height of involvement, extent of involvement, and the involvement of visual axis, we can decide if we are moving towards conservative treatment treatment options or if we are opting surgical treatment. So if we are moving towards surgical treatment, then we have the following options, out of which is metopexy is considered as the standard treatment of choice, in which we can inject air. Air is injected in such cases which have small detachments at the periphery and superior, because the absorption time of air is 3 to 4 days, which is not long enough for larger detachments. So for longer demand and better outcomes, isopropyl gases like perfluoropropanol at the concentration of 12 to 14% and sulfur hexafluoride at the concentration of 15 to 20% are used. Other treatment options are mechanical tamponade using viscosurgical devices, transcorneal sutures using 10-0 monofilament nylon sutures, and for recurrent cases, descemet stripping nasal keratoplasty can be done. Some of the complications of metopexy are raised intraocular pressure, pupillary block glaucoma, and rare uveitis. So prophylactic peripheral iridectomy is recommended in these cases to prevent the complications of uveitis. Thank you.
Thank you, Dr. Aisha. Our next presenter is Dr. Sama Kazi. Please come. Assalamualaikum. I am Dr. Sama Kazi, third year resident at LRBT. My patient is a 61-year-old male who presented to us in the OPD with complaints of sudden decrease of vision, visual acuity in both eyes in 2 days following an episode of fever. The decrease of vision was more pronounced in the right eye, and it more mainly involved the central vision. The left eye also had some mild blurring of vision. The symptoms for both eyes were significant for both near and far vision. He also complained of a mild headache. There was, however, no diplopia floaters or color vision defects. Neither was there any history of pain or redness. Patient gave a pertinent history of dengue fever, which was self-limiting and recovered with supportive treatment for 1 week. And he complained of some mild, he revealed that he had some mild joint pain, which accompanied the fever, but it also resolved with the fever. He also showed us his previous blood workup, which the findings were mostly normal, but his platelet count had dropped to 73,000. These were 2 weeks ago before he presented to us, and he was NS1 positive for dengue. The past ocular history reveals that there was no history of past ocular surgery. The patient uses glasses for near work. There is no history of any ocular or other trauma. There is no history of any injections or laser, and neither has he ever used any eye drops. The patient is hypertensive for 20 years. He is on medication. He has it controlled. There is no history of any other systemic medication. He has a history of 10 back years of smoking, but he quit like 15 years ago. There's no surgical history or family history, and he was a teacher by profession. On examination, we find this well-oriented gentleman, old gentleman, who has a blood pressure of 140 by 90. His peripheral pulse is appreciable and he's afebrile. On his ocular examination, we find out that his right eye had an unaided visual acuity of counting fingers, which had no improvement with ECVA or pinhole. On the near acuity chart, he can read N24, but no, not further than that. The rest of the examination for the right eye was normal. The left eye had 6 vision, and everything was within normal limits. On slit lamp examination, he had some mild blepharitis. He had some mild congestion in his conjunctiva, and the rest of the slit lamp examination was normal, apart from the fact that he had
some multiple vitreous opacities which are non-specific. Intraocular pressure was within normal limits, 17 for the right eye and 14 for the left eye. His dilated fundus exam revealed healthy cup ratio of 0.4, and there were, however, hypertensive changes on fundus, and there were numerous dot plot hemorrhages, a few flame-shaped hemorrhages, and numerous cotton spots, including the macular. The left eye had similar findings on the fundus. The optic disc was healthy with a CD ratio of 0.3, and you can see flame-shaped hemorrhage and numerous cotton spots here. The FFA findings were non-specific, and a few hyperfluorescent and hyperfluorescent lesions were seen. And there was some diffused laminar flow in the inferior artery. That's for the right eye. The FFA for the left eye was almost the same, and he had a few hyperfluorescent and hypofluorescent spots. The OCT of the right eye revealed destroyed macular edema with hyperreflective spaces and some hyperreflective lesions as well. The left eye OCT had a normal fovea, but had some off-center macular edema. So we keep dengue retinopathy at the top of our differential because of the history it gave us and with the lab findings we had. The other differentials that we made were hypertensive retinopathy, vascular occlusion, lymphoma, leukemia, metastasis, and medication retinopathy with interferon retinopathy, toxicity. There's a mistake here. Prednisolone for TMC. Patient was started on oral steroid, delta carotid 8 tablets, and was also started on topical nepafanac 4 times a day. And he was called for a follow-up after 1 month. And when he arrived, there was not enough improvement in his visual acuity. So he started tapering off his oral steroid and planned for a triamcinolone injection with a posterior subtenon approach on his next visit. When he arrived for his next visit, 2 weeks from previous visit, we injected him with the triamcinolone posterior subtenon and called him for follow-up after another 2 weeks. On final visit, we performed examination and which I will reveal just now, and a topical NSAID for 20 minutes. This was the examination on the final follow-up. The right eye had this final unaided visual acuity of 636. There wasn't much improvement with refraction. However, it improved to 624 with pinholes. Near visual acuity also rose to 12, and the rest of the examination was again normal. Left eye still had fixed vision. This was his post-treatment follow-up. There was a generalized vision thinning and some fovea. The OCT of left eye was within normal limits. So, the fundus lesions we see in dengue are often non-specific and include retinal hemorrhages, peripapillary hemorrhages, raw spots, cotton wool spots, intraretinal precipitates, retinal edema, optic disc hyperemia, as well as dengue maculopathy. These retinal changes may occur in isolation or may be associated with some interior uveitis or vitreitis. And unless the macula is specifically involved, the patient may be asymptomatic. The prevalence of dengue maculopathy in patients who are diagnosed with dengue is from some studies has been estimated at 10%. The involvement is usually bilateral in a majority of cases. However, uh, it can be that one eye is more affected than the other, or it can be unilateral as well. The usual presentation is blurring of vision with a central scotoma about 1 week after the onset of fever. Uh, in addition to macular edema, small or small white or yellow subretinal dots could be seen, or some intraretinal hemorrhages, retinal epithelial swelling, vascular sheathing, optic hyperemia. These can be the findings on the fundus. A small, well-defined yellow-orange subretinal lesion is often seen and is pathognomic for dengue nephropathy. It wasn't present in our case, but has been reason to be the major cause of visual morbidity in these patients. Uh, it, it, it's called foveolitis. These appear as focal disruption of the neurosensory retina, outer neurosensory retina, and also cause it's like there's a thickening of the neurosensory retina at the fovea. Other OCT findings include diffuse retinal thickening, destroyed macular edema, and exudative detachment. The SSA and anthocyanin green angiography may be normal, or there could be evidence of small vessel vasculopathy or vasculitis. There is no proven therapy for dengue retinopathy. However, what has been seen is that patients with good initial visual acuity uh, end up having a better prognosis. However, those who present with a initial with poor initial visual acuity or progression of worsening of visual acuity have a poor prognosis. The patients are treated from systemic steroids to immunosuppression. Just like you saw that our patient improved a lot when we gave him perioral steroids. However, the range of treatment starts from systemic steroids to immunosuppression. The majority of patients achieve a good cellular visual acuity, although recovery may be prolonged. Nonetheless, some patients, especially those who have foveolitis, end up with a central scotoma that persists. The conclusion we draw from this is dengue fever history warrants thorough ocular examination, and serious vision threatening disease is possible. There should be frequent follow-up by the patient, and foveolitis, as I just told you, may be associated with a poor prognosis. Thank you. '61. Yes. Yes, sir. He was a नहीं सर मैं पहले तो प्रेजेंट हुआ आफ्टर टेकिंग सर मोस्टली because certain visual loss of stuff और जो हिस्ट्री थी उसकी डेंगू की बहुत फिट करी थी क्योंकि and so the sudden fall the visual acuity में that gave us the idea or unilateral. Sorry? No. No, thank you. Go ahead. Yes, sir. Yeah.
There is cause of thank you. Thank you, Dr. Osama Kazi. Our next presenter is Dr. Kalan Hafiz, third year resident. Bismillahirrahmanirrahim. I welcome you all. My name is Dr. Kalan Hafiz. I am a postgraduate resident, third year at LRBT Hospital, and I will be presenting a case of phacoemulsification in microcornea with glaucoma that I did on a patient who was 48 years old male. He presented with gradual decrease of vision in both eyes. However, left eye vision according to him was worse than his right eye. There was no history of trauma, any surgical intervention, or eye medication. His visual acuity in the right eye was counting fingers at 1 meter and half, and counting fingers at half a meter in the left eye. And vision was not improving with correction. After the examination, and the interior segment was unremarkable other than the fact that the corneal diameters were less. They were 9 into 9.5 millimeters, and immediately there was an iris coloboma. In the right, there was a clear cornea and shallow anterior chamber. The nuclear cataract was of nuclear sclerosis grade 3. We were originally planning to operate on this side. However, on frontal examination, there was a macular hole. It's not very clearly visible here. This was the opacity of the iris. The macular hole was of 720 microns. So we decided to operate on the left eye, which has a grade 4 nuclear sclerotic cataract with a very easy frontal view. The frontal view gave a little bit idea of the glaucoma inferiorly, and visual landmarks were visible like the objective. This was the biometry of the patient with axial length of 24.5. Okay, so the surgical challenges were because of the fellow eye having a macular hole. This was the better eye of the patient with microcornea, weak corneal, shallow the hard cataract, and there is a high chance of complication in such surgery. This was a surgical plan which planned phacoemulsification, high risk of CTR, and dispersive OVD was kept along during the surgery. Okay, so this is the surgical procedure after injecting some viscoelastic device after creation of the main 2.8 millimeter bone. Iris scopes were physically placed to get a better view of the interior capsule. Okay, so triton blue dye was used minimally because of the fear that it may go into the previous segment of the deficient inferiorly. After that, okay, so this was the most challenging step of the phacoemulsification. The whole nuclear and back complex was moving. I should have started with the Utata courses because so however later on I shifted on it because I was taking a smaller axis and I used the Utata to enlarge and complete the axis. Minimal hydrodissection was done, and after injecting OVT, creating some space in the bag, CTR was placed very gently into the capsular bag. So after filling because multiplication was a little difficult, I could not get physical crack or job. So I rotated the nucleus after creating a trench by manually to exert minimal stress on the sonule. And after that, here I could get first complete crack.
So after that, there was not a complete cut, but the piece could be moved a little bit forward. Again, here the nucleus was calcified piece by piece. OVD was filled in the anterior chamber 2 to 3 times to protect the cornea during the surgery. And after completion of the phacoemulsification, okay, the Simcoe cannula was used to aspirate the sheets. It was a little difficult because sheets were being held back by the CDR. However, with the sweeping tangential movements of the Simcoe's cannula, I was able to completely remove the cortical sheets. And here you can see an air bubble which has been introduced to the posterior segment, which I believe was introduced through the inferior deficient granule. After that, the anterior chamber was filled with ocular viscoelastic device and IOL was implanted in the back. And here the iris tubes are removed from the cornea and OVD was aspirated from the anterior segment. This was the first day post op affected. The patient had a corneal site of grade 2 and then grade 2 corneal site and IEP reaction of the cells. We did an OCT just to be sure of that if there was any macular hole present in the other eye also. This is the color comment area. This was 1 week post of patient had cornea and had an IEP reaction of plasma cells, which was actually close to 660 with correction IOP was 12 millimeter of mercury. Patient was satisfied with this PM. And this was the front picture taken after the surgery in his left eye. This patient had an retinoporoidal coloboma, which was congruent with the optic disc. Foveal reflex could not be appreciated in this picture. Okay, let us talk of microcornea. Normal neonatal diameter is 10 millimeters. Anything less than 10 millimeters at the age of 2 is considered microcornea, and newborn of less than 9 millimeters are considered microcornea patients. These are some of the locations of microcornea. Our patient had 2 of them, including shallow anterior chamber and obviously a cataract and coloboma. Okay, so coloboma patient had coloboma probenterior to posterior complete, including iris, zonules, retina, choroid. Coloboma is usually caused by failure of the optic nerve closure, typically chronism. The 2 main types are isolated optic coloboma, which is a little bit rare, and retrocranial coloboma is common. Coloboma may be isolated or associated with other ocular or systemic malformations, such as cleft lip or palate. Our further plan is to closely follow up the patient with retinal seniors, laser retinopexy around the coloboma, monitor for detachment, and management of shallow eye by used for cataract and macular hole repair. Thank you.
Thank you, Dr. Sana.
Now I would like to call Dr. Azra Mahmood, Associate Professor, CMB, Punjab University, for her talk on sample. Thank you.
Assalamu alaikum, everyone. Bismillahirrahmanirrahim. I have been working in Center of Excellence in Molecular Biology, which is famously known as CMB, since 2004. And at that time, we started this work on stem cells. Rather before that, it was started by my mentor and professor, Dr. S. Yazdi, who laid the foundation of stem cell research in Pakistan. And at that time, he involved many physicians along with him, like Dr. Karti and Professor Morgan Tare. And at At that time, I was a PhD student. Later on, we made a team of researchers, send them abroad for training on stem cells to different universities in Germany and USA. So we started uh, stem cell research on different organs. Initially, we started working on myocardial infarction. Uh, then we moved on to ocular repair. In fact, ocular repair was the only organ in which we started our work directly in the patient with the help of Dr. Kazi and Dr. Fawad at that time. So today I'll be just giving an overview about what stem cells are and what could be their possible applications and what are different constraints in the use of the stem cells, as it seems that they have tremendous capability for tissue repair, which cannot be achieved otherwise by the conventional medical modality. So, in fact, what stem cells are? They are special human cells. They are present already throughout our body in different tissues, and they are capable of self-renewal, and they have the capacity to differentiate or convert themselves into different body type cells. In our body, more than as you know, that billions of cells are present, and they could be broken into almost like more than 212 lineages of different types of cells. And however, all these lineages, they originate from a single cell that is zygote, which is itself is a totipotent cell, and it has the capability to give rise to different types of stem cells, and it further has capacity to differentiate into all these 12 lineage types of cells. So the mother cell of all these different types of immune cells is a stem cell basically. These stem cells can be categorized on the basis of like evolution or development. They can be categorized from pluripotent to multipotent type of cells. As you know that a zygote, a single cell, it is a totipotent cell because it has the ability to give rise to a whole complete organism. That's why it is called a totipotent. But as the time passes during the human development, the single cell converts into 3-day embryo. Then it is called when it starts like its growth. It is it converts into like 3-day embryo, 5 to 7-day embryo, and cell division proceeds. As the cell division proceeds, you can pick out different types of stem cells, or you can isolate different types of stem cells from the embryo. The first primitive type of cells that you can isolate are the embryonic stem cells. These embryonic stem cells, they are pluripotent. As I mentioned, that before the embryo formation, when there is a single zygote, it is totipotent. But as the cell division starts, and at 5 to 7-day embryo, the embryonic stem cells can be isolated. Pluripotent means that these cells have the ability to give rise to ectodermal lineage cells, endodermal, and mesodermal lineage cells, which actually form the basis for all the different lineage type of mitoid cells. So further, with the progress of development, by 5 to 6 weeks, uh, embryonic germ cells can be activated. Basically, these are the cells, though they are pluripotent in nature, they again have very good pluripotent means that they have good differentiation potential and they can be utilized for therapeutic purposes. However, these cells have associated ethical issues. Uh, and in fact, even the embryonic stem cells in certain religions like Christianity and other religions are considered unethical for use. So as the human matures or the individual matures, the perinatal cells from the perinatal stem cells can be isolated again from fetal tissue and also from the cord tissue as well as cord blood. The fetal tissue they are mostly pluripotent. Some of the types can be multipotent, like fibroblast cells. If you isolate them from the child forehead skin, they are totally multipotent. But the stem cells, fetal stem cell tissue is mainly pluripotent. Similarly, the cord blood and the cord tissue stem cells, they are also pluripotent in nature mainly. However, when the human body further grows out and as the adult stem cells can be isolated from the adult human body, their potential for differentiation decreases. And like bone marrow stem cells, I have written here multipotent, but some of the papers say that they are pluripotent as well. Like adipose stem cells, they are like a bit of controversy. Some say that they are mainly pluripotent, but some studies report because the isolation procedures may vary. But in general, they are mainly multipotent. So these are the different categories of stem cells, and they can be which can be utilized for therapeutic purposes. And as per recent literature and even our research findings, the adult stem cells or the fetal tissue cells, they are more easier and more convenient to use for therapeutic purposes. And they have a good repopulation or cell renewal capability as well. So in our research, we are mainly using the adult stem cells. Next, most recently, as the regenerative medicine has advanced, induced pluripotent stem cells have also been introduced, and these are the stem cells which have been taken from normal genetic cells of the body, like blood cells or most commonly thin fibroblast cells, dermal fibroblast cells, and they can be converted into these pluripotent cells. It gives you like advantage of like highly population of cells. They are so much they have so great self-renewal capability or proliferating capability that pluripotent that these induced pluripotent stem cells they grow almost with equal strength comparable to the embryonic stem cells. Like in presence of induced pluripotent stem cells, we don't need the embryonic stem cells tedious processes to be followed. So but induced pluripotent stem cells as such cannot be directly used for therapeutic purposes because again they are associated with the teratoma formation. So they are differentiated into the desired cell type and then they are used for the therapeutic purposes. So what are the key factors or how can we determine the choice of cell types when we are so there are different factors on the basis of which we can determine the selection of different stem cell types that can be used for a particular study. For that purpose, we have to consider these points. First of all, ease of isolation. With the embryonic stem cells or embryonic germ cells, the isolation of embryonic stem or embryonic germ cells is very challenging because they are like few cell stage embryos and they cannot be seen with the naked eye with the microscopes in the sterile environment within the microscope, and we have to even the maintenance of that immature cell condition is difficult in case of the embryonic germ and embryonic stem cells. Then comes embryonic cord easy to isolate and usually that isolated out of the liposuction procedure is discarded. So we can again make use of that adipose derived mesenchymal stem cells, and they have like added an advantage that they can be used in an autologous manner. Like fat can be taken from the same patient and then it can be transferred back into the same patient again for therapeutic purposes. Next, uh, the most famous type is bone marrow mesenchymal stem cells, which have been like the most, which is actually the most widely studied stem cell population. However, the isolation of bone marrow stem cells is challenging because it involves an invasive procedure of taking out bone marrow aspirate from the patient. And finally, induced pluripotent stem cells, they are like the isolation of the cells is not challenging, but the culture or the transformation of the mature cells into these pluripotent stem cells is itself challenging because you have to be very careful that all the mature cells have been converted into the pluripotent stem cell population, and a lot of testing is involved for confirmation of those cells and then further maintenance of the immune pluripotent stem cells in an immature state until their further differentiation into the desired cell type, desired mature cell type. So, on the basis of ease of isolation, the use of that the umbilical cord and the fat-derived stem cells is easier or is more feasible. Then, with the embryonic stem cells, ethical issues are associated. Similarly, however, there are no ethical issues associated with any other cell type. So, next factor that we have to consider while picking the cell type or the stem cell type is their differentiation potential, because differentiation potential is an important factor. This is the main factor that we have to use for the we have to utilize after stem cell transplantation. So, on the basis of differentiation potential, the differentiation potential of all these pluripotent stem cell types is great. So the differentiation potential of more immature cell types like embryonic stem cells and pluripotent stem cells is abundant as compared to the adult stem cell types like cord derived, fat derived, or bone marrow derived stem cells. Next, the cumulative or cancer formation potential of the stem cells is high in case of the embryonic and the immune pluripotent stem cells. So definitely, again, we don't want to opt out for the cell types which can induce tumors in the patient. And finally, we also need to consider that whether we have to use the autologous or allogeneic approach for by using the stem cell transplantation. In this regard, the adipose derived mesenchymal stem cells and the bone marrow derived and as well as the induced pluripotent stem cells, they can be or these three types they can be used in the autologous manner as well, as opposed to the cord and embryonic stem cells, which cannot be readily used for the autologous procedure. So, on the basis of these factors, the cord and fat-derived stem cells are the most feasible and most attractive stem cell types that are in the limelight in regenerative medicine research for regenerative approaches. Hence, the capability or to grow and mass produce different categories of clinical grade stem cells along with the procedures to differentiate them into various cell types has led to the use of these cells for the treatment of many for the cell therapy procedure. There are still some technical issues which need to be further explored um, and before they can be like commercialized, before the use of stem cell therapy can be commercialized. However, still due to the abundant regenerative effect shown by stem cell therapy, still it is considered a very exciting therapy for the treatment of different diseases. Internationally, all these cell types that I mentioned, they are being used for numerous disease conditions. Topmost, they are being used for neurological disorders. Secondly, they are being used for joint disorders, for cardiovascular, pulmonary, liver, diabetes, liver disorders, diabetes, bone disorders, muscle, kidney, cancer conditions, skin, and ocular defects. This is just a picture of the different clinical trials that are being run using stem cells in international settings. Almost like, because bone marrow has been the most widely, it starts from the beginning with the advent of stem cells. Bone marrow has been the most abundant stem cell type or most widely studied stem cell type. Next comes the cord stem cells and the adipose and other types of stem cells. And on the basis of disease categories, as I mentioned earlier, neurological conditions are the most prevalent conditions for which the stem cells have been widely studied. Next come the joint injuries, in which stem cell applications have been exploited, and so on. So, in general, there are like currently more than 5,000 clinical trials which have been registered from different countries, which are exploiting the therapeutic potential of different types of stem cells. And they are being done mostly most famously in Iran, China, Italy, France, and some of them are even from USA, Canada, Russia, Israel, Netherlands, and also India as well. And stem cell therapies are very commonly being used in India as well. And in the international scenario, for ocular length, we found that there was one trial registered from China. They were using like endogenous stem cell activation for the treatment of congenital cataract. For cornea, we found 16 trials that were registered from different countries, and these studies involved the use of fungal stem cells, oral mucosal epithelial stem cells, adipose stem cells for the treatment of different corneal pathological conditions. For retina, we found most clinical trials, almost like 58 trials, which were registered from US, Poland, Brazil, China, Turkey, UK, Korea, and other countries. And these studies involved the use of fat-derived stem cells, bone marrow stem cells, iPSC, and the iPSC-derived retinal pigment epithelial cells, and advanced stem cells. And they were used for the treatment of retinoblastoma, RP, macular degeneration, diabetic retinopathy, and Stargardt macular dystrophy. Actually, I included some data for the clinical trials which have been studied for skin disorders as well, because my work currently for the past like 5 to 8 years has been on skin regeneration mostly. So I will skip this one. Then coming to the national scenario, because CEMD is the first institute that introduced the stem cell research in Pakistan. And as I mentioned that we started with the my initial primitive study for my PhD thesis. Later on, we moved on to different other conditions or different other organs. And for ocular repair, we have been, we went directly to the patient because in 2006 or 2007, as I remember, we, Professor S.C. Abdul mentioned, we set up a collaboration with LRBT Eye Institute India, and there was a professor who had already done like more than 2,000 patients with the limbal stem cell transplantation, and he narrated the whole procedure for stem cell propagation, like the limbal stem cell culture, as well as the procedure for the transplantation in patients to Dr. Kasi and his team as well. And so at that time, we used the limbal stem cells into the patients for ocular repair. Then later on, we started a collaboration with Professor Morgan Taran and Professor Javed Akram, and moved on to like skin repair as well. And we have been working on liver fibrosis and cartilage repair and diabetes as well. But in the rest of the organs, except skin, for skin, we have moved on to the clinical application, and for the ocular repair, we are again working on the clinical patients. But for the rest of the organs, all our research is in animals. And in this whole journey, Dr. Atul Kazi has been with us for the ocular research, and Dr. Amir Aziz was also part of our team in the beginning. And internationally, we have some collaborations from University of Miami and from the clinical stem cell lab from University of Miami. And they have actually, we have this collaboration for introduction of like procedures for the clinical grade stem cell production. Because stem cell production for research purpose is different, but you need many quality associated standards to be followed for clinical application of stem cells, which actually in fact raises the cost of stem cell application. And we have recently been associated with Professor Amir Yazuddin from John Hopkins Ophthalmology Department for the work on induced pluripotent stem cells. Although this work is still under planning, it has not been like transplanted into the patients, but they have done a lot of induced pluripotent stem cell derived corneal epithelial stem cell generation. They have transplanted those cells into chimpanzees, and the next phase is to use those corneal patches in the patient. So this was a brief introduction about my group, who has been working at CEMD in collaboration with Vinabam Center and definitely for ocular repair with Dr. Akasi and LRBT. And based on the clinical and research data, we currently we are working, as I already mentioned, we are working for vision impairment and for skin regeneration. We are working or we are doing the clinical trials, and these clinical trials have been registered internationally as well. And like for RP, this is the entity number. If anybody is interested, he or she can track the progress of this trial. Similarly, for skin regeneration, we registered these two trials, and during the COVID days, we did some trials for the COVID patients as well. And all this work, especially the skin regeneration associated clinical trial and the research work, has been done by the support, financial support from ACC, especially ACC, in the form of LRBT project, worth like 7 million. One of the projects was 30 million that I have recently completed, and another was 4 million. And currently we have an ongoing grant or 6 million for osteoarthritis treatment. And recently, in March, I have also won a European Foundation grant from European Foundation, which is worth like 38 million Pakistani rupees. So through this grant, we will be working on renal metabolic memory associated with the effects of diabetes and stem cell mediation in the repair of this renal metabolic diabetes affected renal metabolic memory through this grant. And unfortunately for ocular repair, because we have been mainly directly targeting the clinical patients, and so we recently submitted an LRBT grant worth 14 million for development of cell replacements for ocular repair, and it is still in review. Hopefully, if we are able to win this grant, we will be actively working in the use or exploitation of stem cells for ocular repair as well. So, based on all this background, our theme of work for the clinical studies has been like culture of the adipose or cord-derived stem cells, because as I mentioned that these are the most suitable types of stem cells to be used. And then with the help of Dr. Amir from John Hopkins, we will be working on induced pluripotent stem cells as well for the ocular repair. These cells will be either used fresh or they will be cryopreserved in liquid nitrogen, and then they can be used as desired depending upon the patient's needs. And they will be tested for the quality procedures like for contamination, for their proliferation ability, for the marker characterization before being transplanted into the patient. And for the injection into the patient, all the patient enrollment, everything is usually done with the help of the clinician, and the patients are enrolled, and then they are transplanted by the clinician into different organs like for RP patients or for skin patients. And follow-up data is collected and analyzed by the clinician as well as the CM. So I'll be only speaking about the visual impairment because for things we have like diabetic foot ulcer and PCD formative clinical trials going on. But for vision impairment, we have already done this work on liver stem cells grown on amniotic membrane with Dr. Karthik. And whenever we will, our project, if that is approved, hopefully, we are going to start this work again because definitely manpower and costs are involved with any research work. And for RT, we have recently, there is a clinical trial already ongoing for which we have, I think, 11 treatments which were transplanted with these umbilical cord-derived stem cells. And their data analysis and further research is still ongoing. And for this corneal treatment, corneal pathological treatment, we will be using the induced pluripotent stem cells under the guidance of Professor Amir from Johns Hopkins University. This is just a brief overview of the work that, because my interest is mainly on skin regeneration. For skin regeneration, we are using like adipose stem cells, umbilical cord, amniotic epithelial cells, and the skin cells itself as well, like keratinocytes and fibroblasts, mainly in rat models, but recently for conditions like diabetic foot ulcer and skin reconstruction in clinical trials as well. We use different approaches like in vitro differentiation approaches, priming approaches like antioxidant stimulation, and the use of scaffolds, different types of scaffolds like amniotic membrane, CRP gels, cytosine or hydrogels or other biomaterials. These are keratinocytes that were grown in our own lab. On the finger there, these are fibroblasts cells. These are the characterized fibroblasts. And these are some of the hydrogels or the amniotic membrane on which these cells are grown and then transplanted into the patients or in disease models in animals. For clinical trials, the fatty stem cells, this is how the fatty stem cells look like after uh, 15 to 20 days of culture in the growth under the microscope. And we characterize them and we also study their differentiation ability into different, their capability to differentiate into different linear cell types. Do the high testing for checking the contamination status of the cell and also ensure the vitality status of the cell. Same, this is the team that was used for the limbal stem cells transplantation with Dr. Kazi. And this is the amniotic membrane, and the limbal stem cells were grown on the amniotic membrane, and this fat was later on transplanted into the patient's by Dr. Kazi. For RP, again, the cord stem cells were cultured in Jimna 1 center because there we have developed a facility for clinical grade production of stem cells. And then they were transported to LRBT, and Dr. and his team, they then transplanted those cells into the RP patient. And their data analysis and further report protection are under this. This is how they were characterized and their differentiation potential into different lineage cell types was studied or ensured. So further plan is that first of all we are waiting for the availability of funds and manpower, and we will be following the same scheme of work, and we may be including like lesser degenerative disease conditions, retinal disease conditions, uh, for getting better results or better stem cell transplantation outcomes. And the clinical evaluation will be followed, and the same follow-up points will be considered. So that was all, and I am really thankful to all our collaborators, research students. They have been involved in the conduct of all these clinical trials as well as research studies. Moreover, I also want to mention that our group has published research papers which have almost like more than 200 impact factors only in the field of stem cells. The impact factor for the genetic disease papers that's separate. So if you have any questions. Actually, in the beginning, we were very conscious because there have been published reports about the side effects. But I think besides like slight fever or edema at initial stages, we did not find any major side effects. I think Dr. Kasi can comment for the ocular patients, but I can tell you about the skin regeneration and the COVID patients that we did not find any significant side effects. Dr. Asif.
Yeah, I would also like to acknowledge Dr. Asif and one of my postgraduate students investigating with me, Dr. Hirabat, who was the member for, who was responsible for the STEM Fellowship for Auxiliary Repair, and Dr. Asif was a significant member along with Dr. Taki and Dr. Rian, who were involved in the auxiliary studies throughout.
Actually, it's not a small talk, it's a big discussion. Retinitis pigmentosa is not uniform in everyone. The doctor, Dr. Asif was talking about is a pediatric graduate doctor who did his graduation, then he did his pediatrics diploma, and he is a working doctor. And now, when he came to me, he was not able to walk straight. He would bump into things. So the vision was like he must be 6'9" or better when he did his medical schooling from King Edward Medical College. So Dr. Asif is talking that once the person has come down to vision of less than 5%, then the healthy cells in the eye which can be stimulated become very few. So we should look at those patients and tell them that this is a progressive disorder and your vision is going to go down with age. So earlier, the better. So I tell people the more you have, the stronger you are. The more nerve fiber you have in glaucoma, it's easy for you to be managed. Otherwise, any illness in your body, when you can become weak with age, with time, there is a greater loss. Sir, Javed sir. Today's presentation is from an international figure, Dr. Mohammad Safiq, consultant retinal surgeon, Memorial Institute of Ophthalmic Research, Egypt.
Good morning, everyone. My name is Dr. Mohammed Tawfiq. I'm a veterinary consultant from Egypt. It was a great pleasure and honor from Dr. Hussein, Professor Dr. Hussein Khakan, for this invitation. I will speak about the surgical management of submacular hemorrhage. First of all, what is a submacular hemorrhage? A submacular hemorrhage is a term which describes a condition characterized by the presence of blood in a potential space between the retinal pigment epithelium and the retinal layer. I mean that the space between the neurosensory retina and retinal pigment epithelium, it's a space that we call the subretinal or submacular hemorrhage. Most common cause of subretinal hemorrhage is a choroidal neovascular membrane. It's the most common cause, usually associated with high myopia, age-related macular degeneration, trauma, angiitis streaks. It may be idiopathic, and also even during surgical procedures, draining of submacular fluid and scleral buckle may lead to submacular hemorrhage and adverse scleral perforation during strabismus surgery or association with a localization of melanoma margin during radioactive plaque, also laser photocoagulation. And arbitrating trauma, hemorrhagic retinal detachment, combined suprachoroidal hemorrhage and retinal hemorrhage. And also some may occur in rupture retinal artery microaneurysm and something like this. So, injection of submacular TPE for submacular hemorrhage. This is a reported lectures about the effect of intravitreal injection or for the TPE injection, or sorry, for injections of the TPE in submacular area. And this slide is very important. You need to screenshot of this slide because it's explain to you what is the dose of TPA and what is the brand name of TPA in your market and how to dilute the TPA. The TPA in our country is the marketing name of TPA is called actylase. It's a 50 milligram. 2 vials, 1 powder and 1 sterile water. We need to use 1 vial and one sterile water and 1 powder. Its concentration in 50 milligram, I mean, is 50,000 microgram in 50 ml. So the submacular dose is 20.5 microgram per 0.1 ml. So how to dilute it? 1 ml is diluted on 7 ml water. So 1 ml now is 125 microgram, then take 0.1 ml. So this is the dose for you. It's a 12.5 microgram per 0.1 ml. The toxic dose is 50, so you can inject up to 0.3. This is an important point. Before you go for the surgery for submacular hemorrhage and to inject the TPA, you need to prepare yourself with this cannula. It's called 41 gauge cannula. It's from outside 30 gauge or from inside 41. So you can buy it in the market by call the company, please, I need to ask 38 gauge cannula for submacular injection or 41 gauge cannula. It's the same because it's in an outer diameter 38 and in inner diameter 41. This is a small video to showing you how to prepare. The sterile water is diluted in the powder and use this syringe. The syringe is from mid-1 cannula is titrated 0.1, 0.2. You can put on this syringe at maximum amount of 0.3, maximum volume of 0.3. If you have a Constellation machine, this syringe can be connected with the silicone injection kit, so you can control the injections actively, not passive. So by foot switch, you can inject and you can control and titrate the amount of injection force. So you need to put it in a dripping force, not in jet force. This is a jet force, decrease the amount of injection to take it to make it drip. As you can see, just maximum 0.2, 0.3, go for the trocar and choose where is the site of injection. In such a case, for a moderate size of submacular hemorrhage, I usually inject in the down, in the inferior macular area, in the inferior arcade, increase the volume of the injection until the macula is detached. And may use another point of injection and then put a small bubble of air with a partial fluid air exchange. The partial fluid air exchange, not a full fluid air exchange. And to make the patient post-operative take a semi-setting position, because when he takes the semi-setting position, the air is coming up and pushing the submacular fluid to go to down with an area of that I'm detached with the TPA. And this is a post-operative injection and the improvement. And I'm injecting the Lucents in subtle out there. This is the second day post-operative. And I started to thinking, is it a recollecting of blood behind the macula or it's a rebleeding? So and asking the patient to do the fluorescein angiography, and we confirm that this I first blood. This is an unusual case of fluid air exchange. Make it full fluid air exchange, there is no space for the fluid or the blood underneath the macula to go down. And this is a post-operative of the patient. You can see how it's amazing the TPE work for dissolution or liquefaction of the blood, and the retina pigment epithelium is absorbing this blood. This is an unusual case of submacular hemorrhage. First impression for me, it's an Asian female, 70 years old, and I suspected hemorrhagic AMD. And I go through for the surgery for injection of submacular TPA in such a hemorrhage. You see the OCT of the right eye and the left eye. As usual, I do the vitrectomy and injecting the submacular TPA. But in this case, I first do a detachment of the retina and then injecting the TBA. So as you can see here, I'm not now injecting the TBA. I'm injecting the saline to make a detachment of the lower retina, and after that I injecting the TBA. So I changing the syringe of the patient. The patient is gaining his like 160 visual acuity, and the macula is starting to be dry, and the color fundus of the patient is, as you can see, it's starting to clear, and the vision of the patient is going to be improving. So my take-home message in such a situations of injection of TBA to treating the submacular hemorrhage. Injection of TBA to treat the submacular hemorrhage, you need to know three things. First, prepare the drug. If you don't have the knowledge to prepare the drug, you need to know to have the knowledge to prepare the drug. Second, you need to have the
Thank you very much. Presentations were very good, but there is always place for improvement. और आई होप कि आप थोड़ी सी ज्यादा मेहनत करेंगे. अब जो प्रेजेंटेशन है, प्रेजेंटर्स को ओएसडी की रूटीन है कि उनको कुछ अवार्ड दिया जाता है. तो आई वुड रिक्वेस्ट और वेरी सीनियर मेंबर, वो किधर के नहीं आपके साथ? अच्छा, आई रिक्वेस्ट द सेकंड सीनियर मोस्ट member is Dr. Zaid bin Abdul Qazi. Although he is host, but he is senior member as well. And Dr. Mohammad Jassad is also very senior member. Please, Dr. Jassad, please come over. Now the prize distribution is there. Today, Usama climbing the third position. Please come over to have your prize. The second prize is Dr. Salah Nafis. Now I would like to call the first presenter, who's the first, Dr. Aisha Arif. ये एक बहुत बड़े फख्र की बात है कि आपने जो है ना बड़े सीनियर टीचर से आप प्राइज ले रहे हो. Now I would like to call Dr. Kashif Aziz. और अब मैं रिक्वेस्ट करूंगा डॉक्टर जावेद मलिक ट्रेनर अपोएसटी लाहौर कम हुआ. आज जो बहुत अच्छी टॉक, वेरी इंफॉर्मेटिव, वेरी वेल एक्सप्लेन्ड, that is by Dr. Azra Mahmood. Please, I would like to Dr. Rashid Kazi to give certificate and bouquet. there is always organization support from some pharmaceutical company to hold such academic meeting. And today, meeting is sponsored by Sante. I would like to adjust by Professor. Sante. There's book as well for you. Thank you very much. अच्छा, आज मुझे ओपनरी मार्क्स भी लेने थे और वो सब साइंस भी करना है, तो मैं थोड़ी सी कुछ रियायत की बातें भी करना चाहूंगा आपसे। तो सबसे पहले तो मैं बात कर लूंगा तो बहुत बहुत शुक्रिया स्पेशली LRBT और डॉक्टर जमीर के नाते का भी आपने बहुत अच्छा अरेंजमेंट किया अपनी फैकल्टी टीम के साथ, जिसमें डॉक्टर काशिफ इकबाल है, डॉक्टर फाजुर रहमान है और डॉक्टर जवाद बिनियामिन भट्ट है। आपका बहुत शुक्रिया और सब पार्टिसिपेंट का बहुत शुक्रिया कि आप लोग तशरीफ लाए। अब मैं पीजी के बारे में थोड़ी सी मुख्तलिफ सी बात करूंगा। सबसे पहले तो मैं निवेदन में आ गया कि आप LRBT को बहुत बहुत मुबारक हो कि इस बार इनके आप पीजी जो लकी का वचन है, एक तो जहां की जाते हैं काफी कहीं भी सर्जिकल एक्सपीरियंस काउंट करना हो तो ज्यादा प्रेफर हमेशा LRBT को किया जाता है। तो इस बार पार्टी के एग्जाम में 8 कैंडिडेट्स अपीयर हुए और 6 पास हुए। ये इसको कर सकते हैं और ये सब मेहनत की डॉक्टर आसिफ काजी, डॉक्टर काशिफ इकबाल, डॉक्टर जवाब बिनियामिन भट्ट एंड डॉक्टर फाजुर रहमान। यू आर लकी कि आप लोग वो आप लोगों के पास ही हैं। आई स्ट्रांगली बिलीव कि आपकी फैकल्टी एटलीस्ट मुझसे हर तरह बेहतर है, प्रैक्टिकली, क्लिनिकली, सर्जिकली मुझसे बहुत बेहतर है। इसलिए आप अपनी बातों का जो दामन किया बिल्कुल ना छोड़िए और उनके साथ उनके पीछे पीछे बात से कुछ पाने के लिए मेहनत करना है। इसके बाद थोड़ा सा मैं बताऊंगा कि यहाँ पे अभी जो फॉरेन टीचर थे डॉक्टर मोहम्मद तौफीक, पहले उनका तारीफ कराना चाहिए था, वो नहीं हो सकता, मैं बता देता हूँ कि OSC की रूटीन रही है कि हर चीज जो है वो उससे कुछ शिद्दत लाती है। एकेडमिक्स को इम्प्रूव करने के लिए, आपकी कैपेबिलिटी को इम्प्रूव करने के लिए जो पहले जो ऑर्गेनाइजेशन थी उन्होंने ट्राई किया एक कॉन्सेप्ट देने का कि गेस्ट स्पीकर अगर मैं तो सिस्टेमिक डिजीजेस में से हर जगह पे किसी ने किसी को इन्वॉल्व किया ताकि थोड़ा आपकी जो यूनिट थोड़ी प्रॉब्लम। तो इस ऑर्गेनाइजेशन में डॉक्टर फातान ने एक विजिट किया और उन्होंने मेहनत की कि फॉरेन टीचर को भी काम किया कि आपकी हर सेशन में एक फॉरेन टीचर भी हो। तो ये उनकी प्रैक्टिस थी। तो ये डॉक्टर मोहम्मद तौफीक इज रेकमेंडेशन फ्रॉम एडी। हमने आप लोगों को बहुत ज्यादा मुझे लगा आप लोगों को जल्दी की है, भूख भी लगी है, मैं बहुत दूंगा। नेक्स्ट क्लिनिकल मीटिंग जो है दैट इज ऑन first ever South Ganga officer. तो मैं दोबारा LRBT की एडमिनिस्ट्रेशन एंड जो यहाँ पे फैसिलिटी है उनसे रिक्वेस्ट करूंगा कि आपने सीवी जो है बेशक 10% मुझे पता है कि सबको एग्जाम नहीं भेजा जा सकता लेकिन 10% 3-4 लोग कम अज कम जो है वो दूसरे ऑफिस में जरूर भेजा जाए अब मैं रिक्वेस्ट करूंगा कि डॉक्टर बेबी के नाते चाहिए आके अपना जो लक्ष्य हैं वो आने के लिए बात करें थैंक यू
great teacher, intelligent Javed. Students of the Islamic Education, ये student हैं माशाल्लाह. Great contribution. We are really happy that you have Lord and people like Mr. Javed do wonderful work and doctor. Now the team is ready and will follow the advice of Mr. Javed to participate, inshallah. We can go to room 45.